Welcome to today's webinar, a special conversation with Dr. Atul Gawande. When you joined today's webinar, you selected to join either by phone or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. John?
Thank you, Kat. Today we are celebrating a very special event, 5 years of Grantmakers in Aging's monthly webinar series called Conversations with GIA. With the continuing and generous support of the John A. Hartford Foundation, we are able to offer these webinars to the public free of charge. Joining us for this celebration is a very special guest, Dr. Atul Gawande, surgeon, writer, and public health researcher. Dr. Gawande practices general and endocrine surgery at Brigham and Women's Hospital and is professor in the Department of Health Policy and Management at Harvard's T.H. School of Public Health. He is also executive director of Ariadne Labs, a joint center for health systems innovation, and chairman of Lifebox, a nonprofit organization making surgery safer globally. For the past 20 years, he has been a staff writer for the New Yorker magazine and has written 4 New York Times bestsellers, including his most recent, Being Mortal, Medicine and What Matters in the End. He is the winner of 2 National Magazine Awards, a MacArthur Genius Fellowship, and the Lewis Thomas Award for writing about science, among many other accolades. Dr. Gawande, welcome and thanks for being here.
Thank you. This is going to be fun.
Our audience today is mainly those who provide for older adults in some capacity, including many direct service workers, but also policymakers, grant makers, and other roles. One of the quotes from Being Mortal touches close to the heart of geriatric care. You say, "We want autonomy for ourselves and safety for those we love. Many of the things we want for those we care about are things that we would adamantly oppose for ourselves because they would infringe upon our sense of self." So the question is, how do we balance safety with autonomy? And who gets to decide what that balance is?
Well, first of all, it would be an enormous milestone if we reached the point that we were trying to balance safety with autonomy, right? So the things that really struck me, I tell the story of Bill Thomas deciding that he wants to bring pets to his nursing home in upstate New York and how that caused a revolution. Like, that's crazy. But the idea that that he had was a pretty simple one, which is that people needed the opportunity to care for something and have responsibility, have a living being in their lives, and that people and so he brought in, I guess it was 2 dogs, 4 cats, and 100 parakeets, and so that everybody in this institution who wanted one would have either a pair of parakeets or they would get to interact and have a pet of their own. And virtually everybody chose one, but had to go then lobby with the New York state regulators so you could get an exception. Now here's the irony, is that the actually written regulations do not prohibit the idea that you could have birds or folks like that, but the interpretation of the regulators had been that birds are unsafe, that if you move in a nursing home, you have to give up your pets, you have to give up these things you really care about that mean a lot in your life, that might have meant a lot through your entire life. And he won a interpretation that allowed you to make this happen. And then lo and behold, then when they studied what happened over time when you gave people that kind of opportunity to have something where you could express yourself, your autonomy, your caring, and not just be safe, protected from falls, protected from the animals, that you had people have marked reductions in their use of antipsychotic medications, antidepressants, and they measured an improvement in survival. Now, that to me is the core story in the first place. There is no bright line that you can draw. Another example is in his next, revolutionary idea was in the greenhouse concept was to rebuild the nursing home, not around a nursing station, but around a kitchen. And in the kitchen, there's a refrigerator. And in the refrigerator, you can go and you can take out anything you want to eat. A diabetic can go get a soda out of the refrigerator? Yes, we do that in your own house. You just because you're running a place doesn't mean people can't make this their home. And in being in your home means getting to take risks and manage that, like drinking a soda from your refrigerator. And you know, my mother just moved into a senior retirement community, and we read the documents together. You give up all your rights, your right to make decisions about whether you can live there or not. For example, if you refuse to take your medications, they can make the decision to move you out, right? If you are refusing to take the medications you want. So the failure to recognize that your ability to make these choices, have a say over what you want or need, is crucial. And sometimes your ability to make decisions can be impaired, but then a family member can make your proxy can make choices and decisions along the way. So I think this is a very deep, it's interesting to me you started here, because I think that we understand the focus of aging to be about survival and safety so much from the point of view of adult children who are often grappling with, what do we do with mom? What do we do with dad? And the nursing home directors and the senior retirement community directors talk about the idea that very often, especially at the skilled nursing level, the 24-hour nursing level, it's the adult children who make the decision. And they have to market to the children to make the decisions, and therefore they're telling them all about safety instead of how lonely are people, how much do they continue to develop? Can you continue to have, are you bored, or are you actually growing in your life? Are there things that people look forward to and can continue to look forward to? Do they have the options for making choices, having spontaneity? Those things we simply don't ask about. And so I'm somewhat evading your core question of where do you draw the line? It's having the conversation and being able to make this part of what you negotiate with people and are continually trying to serve. It's like being a doctor. I'm going to have an argument with you about whether you should wear your seatbelts and quit smoking or not. I'm going to tell you that you're making some bad decisions in your life. You know, if you're impaired, I'm going to talk to your family as well and try to get them to be part of making your decision. But do I get to run your life? No.
Right. Well, you know, and I think because you and I both have the situation of having mothers now in institutional level of care, my mother's in assisted living with dementia, that the other thing is that balance changes over time. So you may have a pattern of care that made a great deal of sense when the person came into the institution, but it may change very quickly, or it may change very slowly. And how do you continue to engage people in those discussions as those situations change, both the individual themselves and family members, if there are some?
So I saw this really cool thing that's done that has been adopted in a center in a senior retirement community here called Hebrew Senior Life, where they call it their 360 Vitals report. And you and your family fill out a document that is kind of your story. What are the health issues you've got? Who are the meaningful people in your life? Who are what matters to you most? What are your families and friends? What gives you joys? What's your best possible day? How much does food matter to you versus getting exercise? What are the meaningful ways you'd like to contribute? And there's a kind of health and safety plan that comes out of it to address, but there's also your plan for purpose and joy, and then putting that together. And it's revisited on an annual basis, but then also on an ad hoc basis as you, if there's sudden changes in events. I think it's it's the fact of the conversation and making it really normal to have these conversations. And that's what feels really missing here, right? As we come to recognize the reality of mortality, a limited lifespan, we think of that as being all about, when I need help, that there's going to be, I'm going to turn to healthcare and someone will help rescue the situation until they tell me I can't fix this problem anymore. And that's usually too late, right? When the crisis comes, it's too late to have a discussion about what really matters to you because you may not be able to, or you haven't got the perspective in the crisis moment to be clear about it. And it's not like a one and done kind of conversation either. When people have priorities in their life besides just living longer, what those priorities are and goals are in their life and for their treatment when they need help change over time, as you said. Our most effective way to then learn what it is to have the conversations about what your goals and priorities are. And we have that conversation less than a quarter of the time for people before they come to the end of their life. It needs to happen not just in the last weeks of life. It should be happening at any point where you need help along the way, not even just when you're aging. Right? As soon as you are up against a serious life-threatening situation, or one that's really potentially impairing your quality of life, we should be able to know and have that conversation. What really matters to you? What are you willing to sacrifice for the sake of more time? What are you not willing to sacrifice? What's the minimum quality of life you'd find acceptable? And then now we can have a discussion. How do we make that possible and ensure we're not crossing your right lines?
Let's stick with the issue of families for a minute and family caregivers in particular, which has received a lot more attention. There's been an Institute of Medicine study and others recently about this. We know that, and you tell very moving stories about your struggle personally to be able to care appropriately for your father as his process went through. But we know that baby boomers are much more likely never to have married or to have children. And so we're going to be having a huge increase in the number of people that are coming into older adulthood alone. So is the kind of care that we're talking about really possible without family caregivers?
I should think so. I suspect you've seen that it is, and I've definitely, so the difficult part is it's clearly harder, and it makes the need for these conversations all that much more important. It's not just folks who are single throughout their life to begin with, but also people who may be widowed, lost children along the way, and having a community, having social connections where there are people who know what matter to you, you have clarity about who makes the decision. One of the things that we've been running out of the research center around the Ariadne labs, which we briefly mentioned, we have been doing now 3 years of surveys for the state of Massachusetts with partnership with Blue Cross Blue Shield and the Institute for Healthcare Improvement, and it's now called the Massachusetts Serious Illness Coalition. And so we're surveying everybody across the state, and one of the most critical things is, do people have a healthcare agent, someone who they can make decisions when you can't, because the vast majority of us will come to the end of our life or some point in our life where we can't make decisions for ourselves. Most people have not named who their healthcare agent is, and when we've named who our healthcare agent is, we've often not had the conversation with them about what really matters to you. And so, the flip side question is asking people in the survey, are you an agent for someone? And if so, do you feel you know what the priorities are for people? And it's a large percentage who really don't. So we're down to the vast majority of people have not identified who their healthcare agent is and had a conversation with them about what would living well be for you, and what would living so badly you would not want to be kept going mean for you, and making that come alive. So who are our highest risk people? We didn't actually poll whether being single was the consideration, but what we saw was the most vulnerable population are men who have high school only education or minority, and they're the least likely to have that conversation even when they have the loved one who is in their life, and all the more reason that making these really normal should be the kind of conversation you have with clinicians and caregivers, and that you can have with family. The last thing I'll say is, in our polling, our surveys, we found that among the, so you're down to less than a quarter have these conversations. When they have that conversation, when someone, well, I'll say that almost half of people have had a loved one die in the last 2 years and been there with them and come to that place with them. When they've had that conversation, and that's less than a quarter of the time, they have a better than 85% likelihood to report that the care was of high quality and satisfaction and was in line with their goals and wishes. And it is less than a third who report that to be the case when they've not had that conversation. And it did not matter whether that conversation was with a family member or with a clinician. When they've had that conversation with someone, it is a dramatically different outcome.
That's really good news and important information for us to keep in mind as we design these systems. So let's turn a little bit from the end of life to what is likely to be for most older people the way in which they do live the later years of their life. And it's an article that you wrote for the New Yorker about what you call the heroism of incremental care. And this is for the rapidly increasing number of people with chronic but manageable conditions, so not end of life. So let me ask, why do you see this as heroic? And how do you see that, once again, that balance between safety and autonomy?
Yeah, so this is a really came to me that seemed really interesting, which is the ways, so the healthcare debate in the United States has been unfolding as one that really is about, that seems to be revolving around the idea of, do we at least have coverage for your catastrophes in life? And our whole insurance system is kind of built around the idea that we have to rescue you. And what I realize is that we've been undergoing this really radical transition in how healthcare actually helps you live a long life. The way in the 1950s we managed to do this kind of work was we could rescue you from, we were starting to learn the ways you could rescue you from disease. We discovered penicillin and other antibiotics so that if you have a pneumonia, you now can be rescued from it. We discovered how to do kidney dialysis. We learned how to do open heart surgery. We could address all kinds of problems after they've appeared. Primary care and the ability to do something before a problem has appeared had very limited opportunities. You had some vaccines that had now been discovered and come into place, but there was limited, we didn't know, for example, that high blood pressure is our biggest killer after, now that smoking is coming down. We didn't know that blood pressure was a killer, and we didn't have any treatments to manage blood pressure in the 1950s. As we developed computational power in the 60s and 70s, we then began to be able to track people over time and discover these patterns of what happens in their life. And we discovered blood pressure made a difference. Discovered smoking was a disaster. And now, as we add genomics and other kinds of data in about people's lives, we have more and more of medicine's value comes from being able to follow you over time. And so the life course of healthcare and how it makes a difference, we did an analysis with a Republican economist and a Democratic economist, and myself in the New England Journal of Medicine with Kate Baker and Ben Summers, looking at the last 10 years of data about healthcare coverage. If people, what happened when people got Medicaid coverage, when there were Medicaid expansions, or got coverage under the Affordable Care Act. And the data about it were really interesting because it seemed a contradiction. It seemed evidence that care didn't matter, that when people got coverage, and there were some place like Oregon where they gave it by lottery, so you could really see the difference between people who'd gotten coverage and people who didn't get coverage. When people got coverage for care, in the first year right away, you had improvements in people's financial condition. They had increased use of primary care, got increased access to medicines. They were more likely to get diagnosed with their blood pressure and their diabetes, get the treatments for it. They had surgery much more. They actually probably used the emergency rooms more, not less, along the way. They kind of used more of everything. By the second year, they reported feeling better, but you didn't see big drops in blood pressure or diabetes or things like that. And there was no reduction in deaths. And so everyone said, what good is this stuff? At 5 years, however, you follow the data out for 5 years, and now you saw major reductions in death, 6% reduction in death for people who had a regular source of care and access and being able to afford their needed medications and treatments. And the particular group who had the best outcome, the greatest reductions, were people with chronic illness, HIV, heart disease, cancer care, cancer diagnosis. They had even bigger reductions in death. And that's when you realize it's our ability to see people regularly over time and manage in these incremental doses. I describe in that piece in the New Yorker that, we invest in people and their health the way we invest in bridges. We don't maintain our bridges in the country. We have some 60,000 bridges that are in a state of disrepair that some basic maintenance funds would keep it going for more than 100 years. But we raid the maintenance funds every year. And then the politicians will overspend on building a brand new bridge and letting the old one fall apart, because you get credit for the brand new bridge. No one notices the bridge that didn't fall down. And the value of that incremental care of that bridge is just exactly the way it works for us. And the heroism is we have actually we've taken people from living only into their mid-40s in 1900, into their 60s by the middle part of the century, to today living into your 80s if you have a regular source of care and can get that incremental care. And I actually, I'm a surgeon, and I say, at this point, the evidence is that the greatest value is not from the people who do rescue like me. It is now the greatest added number of years is coming from the people who are doing the incremental care, and by the way, being paid the least.
So what do we need to do to have a system that really reinforces and supports the things that you're talking about here?
Well, I think it's a few basic things. We built the system. You look at who are the top 5, what are the top 5 specialties paid for in healthcare, and it's interventional cardiology and interventional radiology, a couple of surgical fields. It's the rescue people. And at the very bottom are pediatricians, psychiatrists, rheumatology, chronic HIV doctors, palliative care,
geriatrics.
Geriatrics wasn't even listed on it on the profile. It's that ignored, right? And that ability to add value over time is so vastly undervalued just in the pay. Then there's, as a surgeon, I walk into work with millions of dollars worth of equipment available for me to do my best job, my best work that I can. And, a pediatrician or a rheumatologist walks into work, and they're lucky if they have, besides a nurse and an administrative staff member, but, how about a coach or a population health manager who can look out on their population and say, oh, so-and-so has, isn't taking their medicine for their rheumatic disease or for their immunologic condition, or, a geriatric patient has had an admission recently and is on several medicines and maybe at risk of falls, and there are 2 or 3 things we can do that could keep them doing really well in their home and happy, by the way. That we've undervalued, and the reason we've undervalued is because we pay for procedures. We pay for fee-for-service and it's not even just that we pay for the fee-for-service, we have undervalued the incremental chronic management services, and we've highly valued the rescue services. It is a concern to me that the budget that just got approved by the Senate, the big budget that's passed through, included rolling back the authority for CMS, the Medicare, Medicaid Services Program, that if there is a benefit to cost and to lives saved, they had been given the authority under the ACA to shift money so that primary care would get more than, could get more than special, than it had, and might reduce specialty care investment. And of course, the lobbies went crazy and they managed to get it through. So we have to keep pushing forward the idea that moving, I think, away for fee-for-service medicine for this incremental care that we do, having a kind of, the concierge idea of having a flat fee that enables a doctor to work with you across solving all of these different problems and doing it as well as they can, and you pick who you want to work with to direct that money to. I think those kinds of models are likely to become the more successful ones.
Let's pursue that a minute. Do you see other either experimental or models that are running now that really represent the kind of care that you're talking about?
There are lots of examples, but the trouble is that no example has the magic bullet, right? It's not just because you paid people the right way. You don't want to penalize people for doing the right thing, which is what our current system does. But just because you pay people the right way doesn't mean they end up doing the right thing. And so, I've written about whether it's hotspotting, different programs that focus on your 1% or even your 5% sickest has the most chronic illness population, which accounts for, so 5% of our population accounts for 50% of the cost. And if you look at the people with chronic illness in that category, there have been quite successful programs that have focused on hotspotting, as I called it, identifying the people who are at greatest risk, putting more intensive and anticipatory services around them, catching people to work on their blood pressure, work on their, address their heart disease, et cetera. And those have been extremely successful. They've had a hard time scaling because you're entering into a different relationship with people. We just profiled in an article I did with our team here. Actually, I was barely involved, to be honest. The team, our primary healthcare team, had profiled Costa Rica's work in the last 20 years. Costa Rica is about less than a quarter of our income per person in that country. 25, 30 years ago, they were at only 60 years of survival, and we were at 75, 77 years of survival. During that time, we've now gone to 77, 78 years of survival. They decided to shift to this model that says we're going to invest in making sure everybody has a regular source of care from a primary caregiver, and that primary caregiver has a staff member who looks at their neighborhood of patients and proactively reaches out to address whether it's smoking or blood pressure or diabetes, the issues that you have, and sets goals with people along the way. That EBAIS program, as it's called, has been so successful with a country spending that has a quarter of the income we have, that they now have a longer life expectancy than we do in the United States. They are at 80 years in equal quality health. They're number 3 for survival in the entire Americas, with Canada and Bermuda, with all the bankers going to Bermuda, being the other two longest. The United States is like down around 7th or 8th. So this is just major missed opportunity at low cost from not recognizing the possibilities and the priority here, the heroism of that kind of care.
So let me ask you one last question about this, and that's about, there's been a lot of discussion about, as you mentioned, payment sources and payment methods. So we have a pay to rescue system. What do you think of some of the models that have been offered? Pay for success, pay for quality, pay for outcomes, or do you think those are part of the answer as well?
I do, but lots of people are pointing out the disappointing results that have come in the first few years of putting them in place, because and I think it reflects the fact that it's not the incentives that fix the problem. The incentives can get in your way. The best way I'd explain it is, here we are, we're rolling out a healthcare capability that's this extraordinary thing that we have discovered all of the different ways your body can go wrong. There's 60,000 different diagnoses, 60,000 different ways things can go wrong. And we have discovered 6,000 drugs and 4,000 medical and surgical procedures that can make a huge difference in your life. If it doesn't cure the disease, we can improve your quality of life, reduce your suffering, enable your capabilities for a long span of life on average. We're trying to deploy that capability town by town to every person alive. And it is, I think, the most ambitious thing people have ever attempted. So when we go out and measure, how are we doing? Oh my gosh, biggest killer in the country is blood pressure. And we've only recognized, so we have a third of adults who have high blood pressure. It is our biggest killer, causing our biggest number of patients with dementia, stroke, heart attack, you name it. And we only have 40% we've recognized to have it under control, recognized and then gotten it under control. When you take these other kinds of programs, you can drive it to 70 and 80%. And we have examples around the country where they have done that and successfully taken it so the number one killer is now falls to number two. Now, you could make an incentive system and then go back and look and say, oh my gosh, people didn't fix it. What happened? Why hasn't that moved? And there's some fixing that's happened. So what happens is we say, number one, I'm going to train people. So we're going to train them to do the right thing. And you do see some improvement, but it's very disappointing. There's lots of variation. We now put people through, years of medical training. You don't get to be a doctor anymore until you're 40 years old. By the time you're done with the training. So then we get angry, and then we say, I'm going to regulate this, or I'm going to give you an incentive. I'm going to make a pay for good stuff program. And that works to a modest extent. It's very expensive. It only gets you so far. But what really works is you systematize it. You make it easy for the patient and the clinician to do the right thing. So, in our surgery work that we devised, my previous book, Checklist Manifesto, we devised a checklist to systematize making sure that the 19 most common ways that operations go wrong are reduced. We didn't have a payment program. We didn't have an elaborate training program. It was just a simpler way of doing things that could work for the clinicians while also working for the patients. We published it in 2009, and we had 10,000 patients in 8 cities, and the average reduction in death was 47%. We then began deploying it by mainly by coaching at the bedside and having some basic incentive. Washington State had a payment program. In Scotland, they had a mandate, but it wasn't just the mandate. When Canada just mandated that everybody do it, there was no reduction in death. Everyone was very disappointed. The incentive didn't work. In South Carolina, in Scotland, when we did this work, we sent people to the hospitals and stood there and coached at the bedside, saying, "Well, here's where you're trying it. Let's have a team work on how do you make this work better? How do you get the resistors to come on board? That kind of thing." And it takes a while. It takes several months, even if something as simple as a checklist, to get it implemented, get it in the workflow so it's actually systematized. The result, however, is we're at 22% reduction in death in South Carolina hospitals. We're at 27% reduction in death in Scotland. In France, we demonstrated 35% reduction in death across the country. You can't do it just by make the incentive and say, now it's going to change. You have to make it easy for the system to do the right thing, and then not punish them for doing that, and but do reward them. And so that's why I think the incentives are important. You can't get people to do something you're actually punishing them to do the right thing for, but it's all about making the right thing simpler.
Well, thanks. Those are obviously enormous discussions that we're having in the field all over the.
Yes, I'm trying to get you guys to invest more in the kind of systems work that I'm describing here.
Well, and let's turn to that for the next part of our discussion. So we're here today at the offices of Ariadne Labs, which is a joint center for health systems innovation, and you are the executive director. One of the goals of the organization, of which there are many, is for every seriously ill patient to have more, better, and earlier conversations with their clinicians about the goals, values, and priorities that will inform their future care. We've already talked about that to some degree, but talk about how that fits into the overall program that the labs is trying to achieve. What are you trying to achieve here that you don't feel is being achieved in other places?
Well, I think this one, let me zero in on this one because I think it's a really great indicator of the tension we're talking about here. So New York State mandated that those conversations about serious illness and what your goals for care are have to be discussed by your clinicians. And they put it in as mandate. Mayor Cuomo signed off. It was bipartisan. And I guarantee you it's had no effect, right? And there's been a backlash about it. And the fundamental thing about the conversation is recognizing that there is a culture shift at the center of it. And you can't make a culture shift happen by passing a law where you punish people for failing to adopt the culture. And the culture shift is medicine has shifted, and nursing homes and senior retirement communities and home health care, we have shifted from thinking that our role is to be a paternalist telling you what to do as a patient to what I've called the retail mode. The retail mode is I tell you what your situation is. I tell you the options. And then you have option A, option B, option C. Here are the risks, the benefits, the pros, the cons. Now, what would you like to do? And then I will do it. And then you give me a payment, and I get the payment from the insurer, and we're all good to go. When you ask people who have a serious life-threatening situation, here are the options. What would you like to do? What do you think most people say?
What do you think, Doc? Exactly.
You're going to say, what do you think, Doc? And then what we're trained to say in the retail mode and the kind of I'm informative, I'm supporting your autonomy mode, is we're trained to say, I don't have an answer for you on that. There's no wrong answer here. This is for you to decide. So what would you like to do? And people find it incredibly painful, and they feel really alone in that, and they feel totally unguided. And we haven't had a smarter, better way of doing it. I didn't have a smarter, better way of doing it. I didn't understand how to work my way through this with my own father when he had a brain tumor. And over time, I discovered that there were these people on the floor beneath me called geriatricians, and I'd walk by their clinic every day for years, never knowing what they did. And I knocked on their door and said, can I come watch you guys? And of course, that'd be a weird thing to ask, except I said, I'll write an article about you. So then they said, okay, come join us. And I did that with geriatricians, palliative care doctors, and critical care doctors. And the people who were really great at understanding this saw that their role was not the retail role. It was not just to be doctor informative. They saw their role as to be a counselor. And I never really understood, what do we mean by a counselor? And the counselor is someone who recognizes that I have to ask you what your goals are for your care. And if I understand what your goals are for your care, besides just living longer, then I can align my treatment with those goals and what you would consider acceptable, what you would not consider acceptable. And that's a very, very different thing. It's a radically different thing. It is putting us on very much on even terms here, so that when you say, what would you do, doctor? I'd say, well, actually what I want to know is what you would really want to do, and to know that, I need to understand what matters to you. So how much would it matter to you if the treatment meant that you were going to be really sick and you couldn't be at home anymore? That after the treatment, you might not be able to live by yourself, that you would have to live in a nursing facility? How would you feel if you couldn't talk anymore because you would have a tracheostomy, or couldn't eat because you'd have a feeding tube? Would this be an adequate quality of life? I tell the story of one person who said in my book, a family member was talking to their father about what mattered to them most, and he said, "Well, I'll tell you what. If I can eat chocolate ice cream and watch football on television, that would be good enough for me. If I can't, then let me go." And that's like the best living will ever. Like a doctor, a family, you can know what to do, what matters, and you can't mandate that as a law. You have to bring the families, the patients, and the clinicians to understand this is what you need to do. And in our trials here that we've done, so we got the entire Dana-Farber Cancer Institute to do this. We randomized, we trained half of the clinicians in 2.5 hour training programs and how to have this kind of simple conversation, asking a few goals, and then aligning your treatment with a different mentality, a different point of view in mind. We then had also installed it into the system that there's a place that it gets recorded in the record, that you fill out in the record when a patient's told you what their answers are for what matters, and that you would get reminders if you have someone identified as being at high risk of dying in the next year. Not even high risk, just you wouldn't be surprised if they died in the next year, which meant that we should be having this conversation. And the result was you had people getting to over 90% had this conversation, where before you just had a conversation about whether you want chest compressions or not. And you had done so well that you had given people more control over the care, and they reported reductions in their significant reductions in, we saw 50% reduction in moderate to severe anxiety and moderate to severe depression among people in these circumstances. So it's a long-winded story, but it's one in which you begin to understand our work here has been about scaling solutions like that inside the systems. And so at this point, we've taken it from the Dana-Farber. We're now in a partnership with the largest health system in Texas, Baylor Scott & White, where they have trained hundreds of clinicians and installed it in their system. We're now starting it in Eastern Massachusetts with a variety of places, and with the National Health Service in Liverpool. And yes, you're trying to get the incentives right, but it's fundamentally, you have to get the systems put in place for a culture shift and making these normal questions to ask, routine things that everybody can learn to do.
Thanks. That's a really interesting perspective, and interesting to see the connection between the various pieces of the work that you do. I want to spend probably the rest of our time today on an issue that you've written about as well. This past October, you wrote an article called, "Is Healthcare a Right?" This is, as you know, a fierce debate in our society, and there's a lot of yelling on all sides, but your approach was different. You went back to your hometown of Athens, Ohio, a town of 25,000 people in the Appalachian region of the state, to try to better understand what people think about that question. Tell me a little bit about that experience and why you decided to use that approach and what you learned.
Well, so I grew up in Athens, Ohio. Athens County is an interesting county because it's got this little blue dot where there's Ohio University College in the middle of our town, but for 10 counties in every direction, it's went entirely red for Trump. And so when I go home, I'm a classic, progressive type of person. When I go home, and I'm in a public health world where you take it for granted that people would think healthcare is a right. But then I also grew up as a Midwesterner where you believe in, not asking for, not expecting other people to do things for you, and kind of the self-reliant ethos, you make your own way kind of thing. And when I go home, I couldn't talk politics. It was just too painful because I'm friends with people across the spectrum that I grew up with that are back home, and I just avoided it like the plague. But here we were. I was going back home, and it's in the middle of the, one of the periods of rage over the Affordable Care Act, and I decided I had to have a way to talk to people about it. And I decided the way to talk about it was get beyond the politics and just say, what do you care about? So, do you believe your family, you deserve a right to health care or not? And it opened up these conversations about what's going on in their life and what's happening. And, my friends are all people around my age, around 50. And so we're all hitting big things going on in our life. The three of the people I talked to had been bankrupted by their healthcare costs. And almost none of them said they thought healthcare should be a right. And that was unexpected for me. And I then wanted to probe that and really try to understand, all right, help me. I'm surprised by that. Why? Tell me more.
So let me read you the passage where you talk about your conversation with your childhood friend, Arnold Jonas, who works independently, does not have health insurance, and worries about it more than anything else. What you said was, does he feel that he has the right to health care? No. He never thought about it as a matter of rights. He thinks that the political left typically plays down the reality of costs, which drives him crazy. But the political right typically plays down the reality of needs, and that drives him crazy too. As he sees it, government exists to provide basic services like trash pickup, sewer system, roadways, fire and police protection, schools, and healthcare. The key point is that these necessities can be provided only through collective effort and shared cost. When people get a very different deal on these things, the pact breaks down. And that's what's happened with American healthcare. So when you say that there's a breakdown in the pact in American healthcare, what do you mean there?
Yeah, so Arnold is, he's actually my liberal friend. and at least he describes this way in which he feels like, look, he's built every car that he owns out of junkyard parts. But he's like, I can't build the road. That's what I got to all be in it together for. And so in many ways, he's someone who comes from the left side of the view, but he does it in this very Midwestern kind of, how we understand it that way. The other folks who I'd say they didn't think they thought it was right would say that here I am making $17 an hour now. For example, I talked to now a friend who's a school librarian in our middle school, and she's making $17 an hour after 20 some years on the job. She's actually the number 2 in the union for the clerical workers, and she absolutely does not think that that healthcare should be a right. She had voted for Trump. She didn't believe in the ACA, and what she said was, "I'm paying half of my income in taxes and paying premiums for a health plan with a $3,000 deductible, and I don't have enough money to pay that deductible. And I'm watching my taxes go to neighbors who are poorer than I am, not working, to have health care I couldn't dream of, with no Medicaid, with no copays, no deductibles, no premiums at all. Like, I could quit my job and then get Medicaid. I don't think that's the right thing for me to do. So how can it be?" And so when she hears that people would have a right to health care, what she hears is, who else is going on the dole that I'm going to have to pay for, and I'm still screwed being unable to get care? And a couple of those people were bankrupted while having health insurance because they couldn't even afford their deductibles. And that's where the light bulb went on, that the safety net has people who are just above the level of the safety net, and they have no safety whatsoever. And the bridge that I found, and I think this was the important thing to me, was that these are all people I'd grown up with. I know them. I didn't feel like they were in a different moral universe than I am. And so why are we all kind of at these different counter places? And the interesting thing to me is that virtually all of them supported Medicare. And, liberals will hold up the pictures of the people who say, keep the government off my Medicare, and say, these people are idiots. They don't understand this is government. And what they really mean is that they're not idiots. They totally understand Medicare is a government program, but it works completely differently from the safety net. We all pay in, and we all benefit, and we all benefit as equals. We don't get a different deal if you're rich or if you're poor, or if you have, you know, one employer that's got a sweet deal or another where you're self-employed. And in an America where it feels like we're all in an airport security line, and I'm in zone 5, and someone in zone 8 is attempting to jump the line ahead of me, and I'm pissed off about how can that be the case. You know, we just get in these wars around who's in which zone and where. But what they were expressing was when we're all paying in as equals, as well as benefiting as equals, that's what they believe we can share, and that's where you can connect across the divide. I think that's really important though, because we don't often talk about what does it mean to contribute as equals. You know, Medicare is a uncapped payroll tax, and people at a high income are paying a lot more in than they're going to benefit, and there are people at low income who aren't going to pay as much as they're going to benefit from it when they go in. But we're all contributing as we can, and making that possibility is really significant. It really bothers her to see that there are people at 133% of poverty who are working, who don't have to make any contribution, while she might be at 200% of poverty and has a $3,000 deductible, a huge premium that, you know, has some subsidies, but for them it's still a problem.
Yeah. No, a really fascinating article, and all of your writings, of course, I highly recommend. But that was a particularly fascinating one and an interesting way of addressing this very divisive issue. So as we're coming towards the end of our conversation, I have one more question, and then we'll ask you to wrap this up for our audience. But the final question that I have for you is your latest book, Being Mortal. You have it subtitled Medicine and What Matters in the End. So I wonder if you would take a moment and, as one of our most thoughtful writers and leaders in this field, what do you think matters in the end?
For me?
For you personally.
So my wife and I talked about it, and it's sort of ironic. The thing I have to do after this is we're going to complete we're going to meet with our lawyer tonight to talk about updating our will and all that kind of stuff. So we actually recently had this conversation all over again. And we just completely disagree with each other, which I think is sort of interesting. For me, what matters in the end, I feel like I could be Stephen Hawking. I don't need my body to work. I don't want to be in pain, but I need my brain to work. And what I want my brain to work for is being able to communicate with you. I love seeing the story of the world, hearing the story, and being able to tell stories back and make a connection. If I don't have the movie of my memories, if I don't have the story of being able to see the story and convey my own story, if I've become disconnected from who I am, then say, let me go. Or if I'm in severe pain. But really, I mean, if I'm a brain in the jar and you can communicate and I can communicate with you, keep me going. My wife thinks that's really dumb. Her view is like, why do I care whether I'm the same person who I am, and whether you know me or I know you and I can communicate with you and things like that. You know, she's fairly religious. She's like, you know, I'm one of God's creatures, and if I'm alive, what really matters is, do I have joy? You've known me a long time. You know what I look like when I'm happy, and you definitely know what I look like when I'm not happy. And if I'm sitting there in the hospital room, but I'm able to experience joy, or in a nursing home or wherever, then keep me going. And when I no longer can experience joy, when you can't make joy possible, let me go. And, you know, over time, we'll see who we may change our minds. I may move to where she begins to, where she's coming from. She may move to where I'm coming from. It's a conversation.
It is indeed. At this point, I'd like to see if you have what your final comments are for our audience, for those who work in the care of older people, and what you see optimistically about the future of the care of older people.
Well, my main wrap-up would be to say thank you for all the work you do at Grantmakers in Aging. I've seen the work that you and Grantmakers in Aging, Grantmakers in Health, both organizations do, and that's why I'm thrilled to be here, because I think you recognize what I'm talking about, which is, yes, the policies matter and the financing matters, but at the end of the day, it is how we create the systematic tools that are part of the culture and part of the way that are, look, at some point in our life, 80% of us are going to come to need the help of others. And it is either in service of a life worth living or it's not. And just because you end up having some losses over time, frailty, social connections, things like that, there are, and illness, there are things worth living for, and how we enable that comes from, I don't think independence, fostering independence doesn't quite capture it, right? I've seen a lot of work in the aging movement about I want to foster independence, or I want to reduce sickness or improve health. All of those are really good things, but well-being is bigger than that. You can have a life worth living in a condition where you are not independent, where you are not in health, that you can have sickness, you can have significant disability, but life worth living comes from these other themes that we're talking about. And our job as clinicians, as families, as builders in society, people who may create senior retirement communities or simply be a teacher and others, our job is to enable that well-being and potential across the entire lifespan. The goal is not a good death. The goal is a good life all the way to the very end. And I feel like your organizations fundamentally understand that.
Well, thank you so much. I want to thank Dr. Atul Gawande for his participation in today's program and for all that he does to make life better for older adults and people of all ages. I also want to thank the John A. Hartford Foundation for their 5 years of continuing support for this monthly webinar series that brings important topics on aging to our national audience. I would be remiss if I did not thank in a special way Amy Berman of the John A. Hartford Foundation, who was instrumental in putting this webinar together. We'll be making this presentation available to anyone who wishes to listen to it later. Please watch for a rebroadcast link on our website. And you can also find out more information about all of our webinars on our website, giaging.org, giaging.org. And finally, I want to thank all of you for participating in today's webinar. Have a great day.
Thank you, John. Thank you all.